But I am Daniel Zeitler. I am one of the neurotologists in town, down the street at Virginia Mason. And I thank Doug and the rest of the team here for having me. I barely made it. You schedule your clinic perfectly to end at 12, and then your last patient of the day wants to talk for 45 minutes about their revision cochlear implant surgery. So thanks for having me. All right, without further ado, the talk that I'm going to give is about diversity, equity, and access inequalities in the cochlear implant market. I think the fact that this is based around cochlear implantation is somewhat above many of what you all do in this room. However, the themes that you're going to see are perfectly generalizable to just about everything in medicine, frankly, and certainly all kinds of hearing healthcare. My disclaimer, I don't have the, I need the little dongle. My disclaimer is that this work that I have done on this has not been a lifelong passion. This started during COVID, and so I do not consider myself an expert in this, but while many of us were sitting around during COVID doing 1,000-piece jigsaw puzzles, having very adult, responsibly distanced happy hours in your driveway, renting camper vans and driving around to the national parks, we bought a puppy. I did an obscene amount of Legos. This was the Dean Smith Center in North Carolina, where I'm from, as a huge fan and alum. We bought a Peloton, like every family did, and we did our best to conserve toilet paper. But also, during this time, I had a lot of time to sit back and think about my practice, because COVID happened around the time that I had been in practice, about 10 years. So I kind of took a step back. I was out of the clinic, out of the ORs, as we all were, for about 6 weeks, and I really started to think about not only my practice, but specifically my cochlear implant practice. This also happened, as we all remember, around the same time that the Black Lives Matter movement really started to gain momentum. So you may or may not know, this started in 2013 with the exoneration of George Zimmerman when he murdered Trayvon Martin. And then with the brutal murders of George Floyd in Minneapolis and all of the other things that were happening, Black Lives Matter really started to gain momentum. It was also during this time that Black Lives Matter, for better or worse, highlighted the inequalities of healthcare. And this was just one example because it was happening during COVID. This was a systematic review of COVID-related infections. They compared the risk of positive testing between blacks, Hispanics, and whites. And essentially all of the studies that they looked at showed a disparity of positive testing anywhere between 1.5 to 3.5 times that in the people of color versus whites. We also know, or hope you know, that it was during the same time, again, in the background of Black Lives Matter, in the background of healthcare inequalities, that the systemic issues of racism and healthcare inequalities started to come to light. We at our hospital had the White Coats for Black Lives movement. I'm sure many of you had that at your hospitals. But really, we started to dig into the systemic inequalities of healthcare and the way that we administer it, certainly in America, and I'd love to hear comments about the UK, but certainly in America, it was blatantly and really sadly obvious. So I had a lot of time. I took a deep dive into the literature, and as you probably expect, lots of articles about healthcare inequalities, and these are just a handful of those that relate to pediatric and adult cochlear implantation. So I started reading through these, and I said, well, you know what? My practice cannot be guilty of this. It's impossible. I have to be a good doctor. I am sure that I am treating everybody the same. So we took a look at our data at our institution. We had about 600 implants that we took a look back, and you can see that, other than white people, which we implanted, so we use the zip code of our hospital as a reference. So we have about a 72% white predominance of racial distribution in our zip code, and we were implanting them at 90%. You can see for the blacks, we were implanting about 1/10 of the population, Asians about 1/2, American Indians about 1/2, Hispanics a little less than half, a little more than half. So I was upset about this. So I said, okay, well, that must just be the district that we're in. I'm going to look at Seattle as a whole. And sure enough, it got even worse. So our own practice was guilty of the same systemic problems that I was reading about. This was a shameful realization. So we said, all right, let's take a deep dive in this and let's really take a look. And so what I've done, again, is really just compiled some of the literature. We are now just starting to do some real-time efforts to make this happen and to fix these problems. But this talk is more about some of the literature, which I hope to open your eyes about, like I did mine. And it's important because, and I love this quote, cochlear implants are an amazing piece of technology, but they're only as good as the number of people whose hands and heads we put them in. If they're sitting out there, but they're not going into people's heads, or they're going into people's heads at an unequal clip, that's not utilizing the technology. This was the first real article that you can kind of find in the literature about the systemic inequalities. And this was actually, believe it or not, done by some of our folks right here in town. Ryan Stern, who's still with the UW, Kathy C., who's also with the UW, Bevan, who's left, and I think Susan just retired, if I'm not mistaken. But they showed that white children were 3 times more likely than Hispanics and 10 times more likely than blacks to get a cochlear implant. And this was done with national data. And this was disturbing, but more disturbing was the fact that this was in the background of lower income children being at a twice as likely chance to be deaf, and minority children having a much higher chance of severe to profound hearing loss. So these numbers are probably even more inflated than they appear in the literature. Cedric Pritchett, who's done some phenomenal work at Nemours Children's in Orlando, looked at both race and insurance as it relates to pediatric cochlear implantation. I've highlighted here where I want you to look, but you can see, again, if you compare, if you use the non-Hispanic white as the baseline, there weren't even enough patients who got implanted under the age of 1 year in the black population to compare them to, and they were about half as likely to get implanted at under age 2. Same thing with Hispanics, about half as likely and about 2/3 as likely. So big differences in race. If you look at insurance status using private insurance as your baseline, again, Medicaid patients were about 1/10 as likely to get implanted under age of 1 and about 2/3 as likely under the age of 2. Okay, so let's say that's terrible, it's scary, but maybe it's just because we're using insurance as a bellwether for race, right? So if you then take privately insured non-Hispanic whites and compare them to both privately insured blacks and privately insured Hispanics, again, the same trends. Half to 2/3 is likely in these groups to get implanted under the age of 1 and age of 2. So race seems to be a problem separate from insurance. What about if you take away the cost of an implant? So some people may say, well, a hospital doesn't want to do a lot of Medicaid implants because they're going to get reimbursed poorly. There's negative pressures. So maybe the socioeconomic disparities that we're seeing really are just manifestations of insurance reimbursement. So let's find a state where insurance reimbursement can be wiped clean and then compare things. So that's what they did at Case Western, Cliff Magarian and his group. And the reason they were able to do this is because Medicaid reimburses at a very similar rate in their state to private insurance. And what they found, you might not be surprised, is that eligible children now, we did see some of those gaps between race and ethnicity close, but lower socioeconomic children were implanted almost 8 times as old, so 8 years versus 1 year. They had a higher pure tone average at presentation. They were half as likely or even less to get sequential bilateral. They had almost a 5 times rate of complications, and they had very poor compliance when compared to their underrepresented counterparts. This is not working anymore. Diego Preciado and his group in Washington, D.C. looked at another metric, specifically time to auditory competency as well as ling proficiency between patients with public and private insurance. The time to auditory competency they used as one of 3 things: speech detection threshold, speech reception threshold, or a pure tone average 20 dB or less. And while you can see that private and public insured children did non-statistically significantly different here, the time to Ling proficiency, which is just one measure of performance, was drastically different. In fact, it was 46 times different between patients with public and private insurance. So that is inexcusable. The question is, are these people just born to not perform as well? Of course not. Something about our system is putting these patients at a terrible disadvantage. What's interesting, though, is if you ask why, if you administer a survey to the parents of these children, and you ask, why do you think it's hard to get an implant, this paper was shocking. So it shows, as you might expect, as I've already told you, that the time to diagnosis to implant is drastically different. But people with public insurance do not cite barriers in the system. They will tell you, yeah, we didn't really find any problems, we just took a long time. But if you ask the people with private insurance, they say, oh, we had to fill up our Volvo, and then we had to take time off of work, and you wouldn't believe how much we had to pay the nanny to stay with our other kid while we took our kid to the hospital. So amazingly enough, it's the privately insured people that see barriers in the system, not the publicly insured. Diego Preciado, by the way, says that this changed the paradigm of his practice, this paper. Also, you can find that there's differences in maternal education. So this really neat paper by the folks at UCLA looked at socioeconomic characteristics, and what they found is that those patients who got a CI under the age of 2 had a much higher rate of maternal education. This is not new in this is not new in medicine. We know that maternal education is a bellwether for many things as it pertains to healthcare and healthcare administration. But it was shocking again to see this in the cochlear implant world. Is it because they're better able to understand the candidacy process, or can they read the materials? Is it that the patients who have people with educated parents are getting hearing aids at an earlier age? I don't know, but again, these are scary trends. There have been some really nice systematic reviews about pediatric cochlear implantation. 3 minutes left? Uh-oh. All right, well, there are bad things that we find with access and use as it pertains to socioeconomic and racial disparities. What's super interesting, and I, again, hope we can talk about this, there's almost no literature about inequality of race outside of the United States. You do not find it in the UK literature. You do not find it in the Australian literature. This is a United States systemic problem. And why that is, I have no idea. We are not the only country with people of diverse ethnic and racial backgrounds. We also found, again, and I'm happy to share these slides since I'm running out of time, that if you look at outcomes, again, very systemically prevalent and consistent inequalities. And what came up here to me is, do I ask about socioeconomic status or maternal education when I'm counseling these patients? No, of course not. And I would be shocked if any of us did. But shockingly, it probably has a huge impact on whether your patient comes back to the clinic after they've been implanted. And maybe if the parents aren't educated, we need to have a social worker involved to give them a call. Or maybe we need to get some kind of services out to that patient to make them a little more willing to come in. Have we improved? The short answer is yes, but. So if you look at the trends in 15 years in pediatric implantation, you can see that while the Medicaid patients have significantly increased, the number of patients with private insurance have decreased. So yes, we're doing better with the Medicaid, but are we doing this at the expense of another group? Should we be going down to the lowest common denominator to make everybody better, or should we be bringing everybody up to the highest common denominator? This slide suggests we're doing the former. I would recommend we do the latter. Similarly, quartiles of income, same trend. Medicaid getting better, but private insurance getting worse. Same thing with race. Hispanics getting better, whites getting worse, blacks staying the same. But some of these are confounded by some variables. For instance, are there changes in the rate of implantation a function of the changing population demographics? We've already talked about the fact that children of color have a higher risk or higher prevalence of severe to profound hearing loss. So some of these trends, just that manifesting. And the answer is no, because if you change this into a prevalence rate of the number of implanted children per 1,000, you see the same trend. There is a huge and very statistically significant difference between whites and both Hispanics and non-Hispanic blacks. I'm gonna, for the sake of time, move through this quickly. Just so you know, the WHO has shown that social determinants of health account for as much as half of health outcomes. These are things we have to think about when we counsel our adults moving into adults. And again, for the sake of time, I just want to show two different studies, one out of Emory in Atlanta and one out of UT Southwestern, where they show very, very elevator pitch summary that the rate of people who are being implanted that are white far outnumbers the percentage of people that are white in that population. The other number that I want to show you is this. This is the data out of UT Southwestern. You can see here that if you take race, these patients are, so non-whites are 3 times as likely to qualify for implants, but they're half as likely to actually get surgery. Same thing with English speaking, about 2 times more likely to qualify, but half as likely to be implanted. And if you take this and do a multivariate analysis, you still see that non-whites are half as likely to get implanted if they all qualify as are whites. So these data are reproducible, scarily reproducible, just about everywhere you look. So to finish up, a few thoughts. If the root cause of systemic inequalities is biologic, and it's not, I'll tell you right now, I promise you it's not, then there's something else happening. Equity has to be both normative and empirical. We have to look both to modify our own practice, but also we have to modify the ethics of the way we practice, right? It's not enough to just say, I'm gonna see more Hispanics. We have to figure out why we're not seeing the Hispanics. And it's much more difficult to do that than it is to say, I'm gonna change my practice. I already mentioned we cannot bring the high down, we have to bring the low up. We cannot achieve the lowest common denominator, we have to get to the top of the pyramid here. So I think we all need to do our part. We need to collect our own data. We need to merge it and leverage that data, because big data for this kind of thing is the best data. And we have to expand access and entry points into the CI market. We just met a group of us, about 15 of us on a call 2 nights ago. We're gonna start a diversity, equity, and inclusion think tank about how we can fix these problems in our country. Many of the people whose papers I've cited here are on that call. If anybody has interest, please let me know, shoot me an email, send me a text, pull me aside while I'm eating my fried chicken, and I will be happy to talk about it. Sorry to rush through that, but thanks for the opportunity. And if there's time for questions, happy to do it. If not, we can talk about it over coffee.
Thanks, Dan.